Thank you, Tiasha, and it's good to follow two speakers who had a bit of a different perspective, where Charlotte was talking more about the patient record, and of course Patrick was talking about the hospital record. Now, obviously, we need a solution for both, and I think it's hard to talk about the patient record if we don't fix the records in the healthcare provider space, because that's where the data originates, at least most of the data. So we need to come together on this. Okay, so I will skip this. I will just say that we are now quite active in a lot of accounts, and a lot of these are big hospitals. And this is evidence of the fact that this approach is taking hold. And the difference between a few years ago and today is that we can actually now point to real organizations, not only small hospitals, but huge or actually market-leading hospitals like Karolinska and others. And the other thing which is quite significant is that whole regions, countries, cities are taking a similar approach, which gives me a lot of confidence that this is something that is gaining ground. I'll mention these four because you heard from Karolinska, so obviously they are the #1 hospital in Europe, but also the others are top 10, top 20 hospitals in Europe, and they're adopting the same approach. And it's important to note that they're not killing the existing EHR. In fact, some of them are buying the EHR at the same time as they're putting a platform in place. And this is basically what I will talk about today. So why is this happening? Again, this is a crowd that doesn't need an introduction to the problems of health IT. I've used this slide. Actually, this is also probably 10 years old, but it's still true. It's still true. And there's many others, and there's studies about burnout, about IT systems induced burnout. There's studies for a complete overhaul of healthcare records. And this is all well known. And yet, we are here today and we're talking about the fact that this is not going away. And if anybody has been in the space of trying to replace an existing EHR, you know the pain. It's almost impossible to replace it. So the problems, again, there's a long list. It's well researched. Many of you are feeling this pain if you're a clinician or if you work in health IT. So there's nothing new there. I'll just go into three of these problems and try to explain what the problem is, and then hopefully in the next section you will see how we can solve some of these. So usability is an obvious one. This is a study that says no UK EHR met the international validated standards of acceptance of usability for information technology. That's really, okay, it's really, really a strong statement. Jordy's been saying this for years, that despite the fact that we're talking about, I remember 20 years ago, the data will follow the patient. This was the slogan. It's not happening unless it comes in a box and the patient is actually taking the paper records with him. This one is quite interesting because we say, okay, just buy one EHR for the region and you will solve the interoperability issues. Well, the research says otherwise. In fact, this is actually, patient Dave told me the same thing yesterday. He goes to 4 different hospitals. They all have the same EHR, but he has 4 MyChart portals, which he has to put together to figure out his condition. The customization is another one. Of course, vendors, and this is where most of the cost comes. So vendors struggle to provide exactly what the users need. The products can be somewhat customized, but of course, it's a long way from meeting the needs of each department, each user, each specialty. And again, a long list of things which need solving, and definitely one size fits all is not fit for purpose. So we come to the postmodern EHR based on this, and this is a term that I took from Gartner, because Gartner was talking about the postmodern ERP. And I think it's good to look at other industries, especially because healthcare tends to be 5, sometimes 10 years behind other industries, so we can learn from them and how IT architecture has evolved in those settings. So definitely best of breed was the thing for ERPs in the 90s. Then we got the modern ERP. You can think about SAP and other products, which was a one-size-fits-all. You could customize it. It had a single vendor, single throat to choke. But of course, after 10, 15 years, what started happening is quite interesting. Departments that actually had CRM in SAP went and bought Salesforce. Or they bought, I don't know, HubSpot or Workday and so on. And of course, the integration was built in, so it was a little easier. It came with a different business model. It was usually cloud-based, pay-as-you-go, subscription, very different from the mega suite. And that's the situation we are in today. What this does is that the mega suite shrinks. And actually, you get a lot of innovation around the core, but of course, you cannot replace the core anytime soon. So I challenged Gartner, this was probably, well, more than 10 years ago, to say the same thing about the EHR, but they wouldn't. They said, no, you know, healthcare is more complex, the data is complex, and actually you just want somebody to take care of the integration for you. It will not work. So we did get the mega suite, and it's the predominant architecture of today. But what we are now seeing, especially with the hospitals I mentioned, is that they are starting to do this shrinking of the EHR, and they're buying modules built on a different architecture. And what I have added here is that for this to work, it has to have a common data layer. And the reason for that is that, as I mentioned before, the integration in healthcare is much more complex. Plus, we want to keep this data for a very long time, which is a big difference to other industries. Other industries don't keep data for 50 years. Here, we would like to have the data for the lifetime of the patient. So what this also does is it brings the architecture from something that is where the data is tied to applications, it brings it to a longitudinal care record. Yes, this is inside the institution, but as Patrick showed before, if you have this standardized, it's actually not that difficult to collect the data for a region. And I think this is the way forward, and like I said, I'm glad to see leading hospitals adopting this concept. So, postmodern EHR is basically a combination of the core EHR, which shrinks, best-of-breed applications, but in a different way. They're pre-integrated, they're based on a vendor-neutral data model. They're sometimes built using low code because we have to accelerate this transformation. And of course, ideally, they would have a design system, meaning that applications built differently would actually work in a similar way so as not to confuse the end user and cause safety issues. Okay, so if we look at this at a deeper level, there's many aspects where best of breed and mega suite compete. And we don't have time to go through all of these, but it's safe to say that best of breed is best for some, and mega suite still is pre-integrated, obviously. The maintenance and support from a single vendor, the data consistency is there, even though it's not open, but it usually has a consistent data model, at least most of them. Whereas, of course, innovation, speed, flexibility, customization, things like this are the advantages on the side of the best of breed. So how do we put those two, the best of each one of these together? If we use a vendor-neutral data layer, if we use pre-integrated software modules, a design system, and standardize the data models and terminologies, we can actually get the best of both worlds. And I think this is what these hospitals are trying to do. And we see more and more hospital chains, regions thinking in this way. Okay, so how do we do this? Obviously, Patrick explained what Karolinska is doing. But these slides, again, are very old. I won't say 10 years because my team laughs at me because everything is 10 years. But it's true. So we have the core EHR, but we also have a lot of other applications. And the best place to start is with those other applications. Patrick was mentioning PROMS, an oncology system, things like this, because this is the one that's hardest to replace. So what we say to customers is, look, when you're about to build one of the next applications or purchase the next application, do it on a platform. Start moving the data from the legacy environment into record based around the patient. And then as you add more applications, without giving them their own data, having to concede data to a common platform, you are able to reduce the variation of all those applications. And there's hospitals that have thousands without really touching the EHR except pulling the data out. Now, once you do this, of course, the focus shifts. And this is the bimodal world where you have a system that runs the business, but you also have an innovation platform where you can do all the new stuff really quickly, hopefully with low code, so it's even faster. But you're not recreating the same problem as you had on the left, where the data was tied to the applications. And again, this brings us much closer to a patient-centric record, because this data is organized around the patient, whereas most applications, if you think about it, are built for institutions, not for patients. Okay, so who is doing this? A few examples. You heard yesterday from Luke, One London is an example of this, because we are embedding the centralized applications into the EHRs, creating this postmodern approach. Yes, this is a regional example, but it works really nicely because we have an innovation platform that quickly builds, in this case, care plans, and pushes them out to the entire environment of London City. And here you can see some examples how the care plan is embedded into Adastra in this case for mental out of hours, I think. Then we have partners like Alcidion, which embeds an application built on the platform into their environment. We have in Australia Telstra embedding the application into their environment, and many others. Tieto is a company that's here that does the same thing. But this is the hybrid, which for the end user looks like one application, but underneath it has the two components, the EHR and the innovation platform. Or the Christie is another example. They have a homegrown system, which they are slowly modernizing by replacing or building or rebuilding the components, but this time basing the data on openEHR, on a common data format. And they're also very keen on research. So their research platform today has huge issues putting data together from all the systems. So they're doing this on openEHR, and they're going to do the operational data on a Fire server, basically creating the postmodern EHR through their own development. Patrick didn't use this slide. I was happy because I can use it here. But at the moment, what they're doing is they have a legacy EHR. They're in procurement for a new EHR, but they will take all the data out of the CGM product, put it in the platform in a patient-centric record, start building applications and buying applications on top. And when the new EHR comes in, they will also have the data migrated already to a central record. And the interesting thing is, for instance, in Basel, which I think there's a presentation later on, same thing, one procurement, the EHR plus the platform, two separate lots. And the request is that the vendor will submit all the data from the EHR into the platform and will have to accept forms built on the platform inside the EHR. So I think this is a very practical model. You can also start very small, which is important. We heard before how long it takes. Patrick didn't want to speculate, it will take years. But you can start small. Usually it's proms, it's a smaller application. And then you can start shrinking the EHR, replacing it with new innovation as you go along. Okay, so what's next? There was a lot of talk, obviously, about AI. And I think this is a recent Gartner slide that talks about what needs to be in place for AI to be useful, for data to be useful for AI. And I think it's really important to recognize that openEHR actually solves a lot of the issues of structure, semantics, accessibility, of the need for AI. So I think we are in a really good position to serve quality data to AI, to have data which AI can actually consume and accurately understand. So this is one of the key points going forward, because as Patrick also said, getting data from these different systems is the hard part. Once you do that, you can build applications on top, but you can also do research and use AI, use it to teach AI. The other thing which I would argue is that this just came out, but it's a very, very strong statement. LCAP are low-code application platforms. And again, other industries are much more advanced than healthcare. They are using this big time. In healthcare, we have not seen low-code being used in the clinical space. It's being used in CRM and in the patient administration parts. But the reason for that is that low-code really needs to be based off a stable data model, hopefully an open one, for it to take off for the clinical space. And I think it's important to understand that healthcare has even less IT resource than other industries. So this is definitely one of the areas where we see a lot of interest. And as a company, we are building components which allow you to make more and more complex applications to speed up the process of developing these applications. Because I think, again, we have a huge backlog in all settings. And in order to build out, we need tools and components, which this is a component which can be configured inside a low-code platform and work as soon as you add data to it. Okay, just how we are seeing the market. There's two different markets. There's a market that says, I want to build something, give me a platform. And you saw yesterday the EHA clinics from Nigeria did this, but also Karolinska, they're building their own stuff. And then we have a use case buyer who has an application, but it's based on a platform. So the platform basically gets introduced through the application. In a lot of cases, they don't care about what's underneath, and that's fine. So what we are now doing is expanding the existing platform and looking for partners to build some of those additional modules to make it easier for somebody to adopt whichever one of these they need. Currently, we're strongest in EPMA, and it's introduced us into a lot of customers. But of course, hospitals are starting to build or buy these modules, but then also regions are doing the same. And this is an interesting phenomenon where a region buys a module for the entire region. We're doing this in Wales, in Catalonia, in Slovenia, obviously in Greece. And the interesting thing is that it's the same software and the same platform. And the thing we're adding now, of course, is AI, because again, you cannot talk about health IT or any IT today without how this impacts AI. So this then becomes the platform, and I will just finish with a video of how we see the EHR evolving going forward. Hopefully this works. Oops. Yeah. No? Can we get sound? No. we get some sound? There's nobody there. We can. Let's do the video first and then do the questions.
In clinical environments, good clinical information sharing is crucial for better outcomes. A health record is one of the main information sharing tools. Yet in its electronic form, it still seems more of a burnout-inducing documentation and administration tool than what it could be. An electronic health record should really be a collaboration tool, one that enables safer and easier way of sharing clinical content and improves communication among care teams. We wanted to support the collaborative nature of providing care by reimagining the electronic health record as a communication and information sharing tool. Such tools should not only integrate patients' full clinical picture that an electronic health record offers, but also make reliable and clinically valid original data easy to share. Furthermore, it needs to allow for the knowledge gained and decisions made during the communication to become part of the record. No medical errors due to incorrect copy-pasting of data, and no privacy concerns due to third-party messaging apps where access control to patients' data is not possible. First, we thought about how shared knowledge can improve the quality of information in the record. So we added a commenting system that complements the structured data and the documents and is later aggregated into the patient's wall. On the patient's wall, patient documentation can be discussed and commented on. The patient wall gives care teams an overview of what has recently been happening with the patient. All patient medical activity is kept here, ready to be shared. Creating and accessing clinical notes from the patient wall is also possible. But what we also looked into was how better information sharing can give users greater freedom in communicating with their colleagues. We asked ourselves, how could we make communication more efficient and along the way decrease numerous distractions, such as non-urgent phone calls? We made sharing and accessing patients' data within clinical conversations easy and intuitive. By adding a clinical context to all conversations related to patient care, we decrease the possibility of human error in the communication process and give a more accurate and comprehensive view of the patient's condition. We also thought about the next steps following a conversation between clinicians, such as reports, prescriptions, or tasks. These can all be seamlessly created right from the conversation, and once created, become part of the record. Combining an electronic health record with the communication systems gives care teams a simpler and smarter tool for coordinating and delivering better care.
Okay, so this is still a prototype, just to be sure. There's many people interested, but we haven't built all of the components yet. Tiasha, questions?
Hi, hello, my name is Marlene. I'm in Wales. I have a question. We've heard about prevention, and we know that education is a really good tool for prevention. We heard Patrick talking about getting the clinicians involved, and we now talk about creating a postmodern EHR. But I was wondering, what are we doing for educating our clinicians from university? Are we doing anything? It's more a challenge probably than a question. But if we manage to get the clinicians involved from the beginning, the same way that you learn to read a pathology sample that you might never do if you're a surgeon, but you know how the pathologist thinks. If you teach how to learn about informatics, you might get some people in informatics, but you might also trigger a chain into everyone structuring the data correctly, getting better information from the beginning. And I don't think we're doing that. So it's probably just wondering, what are we doing and what can we do?
Yeah, well, at the moment, I think it's still the special clinicians who understand IT who are the champions, like Patrick and others. Later you will hear from Amanda, who's an oncologist. So one way we see this is that with making stuff easier to use, the local tools, the clinicians actually have a much bigger impact on how these applications are built. In some cases, they're even building them. So the other thing, of course, is that we're getting younger and younger clinicians who are used to using these digital tools. So I think some of this problem goes away from the start. But of course, the decision makers usually still need a lot of interaction. And I think Patrick answered this. Did he say they needed a spine to make brave decisions? I don't know. You know, we talk about this. We're trying to engage with universities. We're putting some of this stuff in, I think it's 12 universities now have an educational program where they teach students. I think that's the only way. You know, we have to show what's possible. And that's the purpose of this video as well. It's not really to sell an EHR. It's to show what's possible and to have people think that maybe there's a better way. No pun intended. But I think that's the key thing, right? It's really hard to imagine things unless you can see them. And I think the way the openEHR community has grown, we can now point to examples. You know, the best way is for Patrick and the clinicians to talk to other clinicians. It's much better understood than if it comes from IT. But I do agree with you, and Luke said the same thing yesterday morning. It should be the clinical champions running these things. Because they have a totally different way of interacting with other clinicians, and of course they have the credibility, which we don't. But if you're thinking about your organization, find the clinical champion. Usually it's enough if there's one, if they're powerful enough. And that's the story of openEHR. It's the clinical champions that have brought this to the front.
Thank you, Tomaz. So let's give him another round of applause.
Thank you.